लाइट चली दो, एक लाइट चली दो। ना ठीक है। So first of all, what are the indications where we actually do ultrasound of the elbow joint? So let's start with the commoner indications. First of all, when the patient is having pain, trauma, swelling due to some injury of the tendon, there is ligament rupture, there is dislocation, there is fracture. Definitely, the bony abnormalities are better evaluated with the help of X-rays or CT scan. But for the smaller bones, the bony irregularities can also be observed with the ultrasound, along with the changes in the tissues can be observed. Now coming to the overuse syndromes, there are a lot of sounds. No, it's because of here. Sound band karo, no. Hello? There are a lot of noises. Hello? Okay. So, these are the conditions like either medial or lateral epicondylitis or in case of enthesopathies like triceps tendon enthesopathy, they are the indications for performing the ultrasound of the elbow. Now coming to the inflammatory disorders, if the patient is suffering from the rheumatoid disorders like rheumatoid arthritis, commonly because it affects the peripheral or the distal joints first. So in those cases, we can evaluate the joint with the help of ultrasound. There may be bursitis and inflammation in those areas that can also be evaluated with the ultrasound. Next is the entrapment neuropathies, and common entrapment neuropathies is the elbow or the cubital tunnel syndrome and the radial tunnel syndrome. There are other entrapment neuropathies as well, but these are the most common entrapment neuropathies, and that can also be evaluated with the help of the ultrasound. So that are the common indications. Coming to the anatomy part, so we all know our elbow joint is actually a junction of three bones. What are those? First of all, from above it is the humerus. From below there are two bones. One is the radius, another is the ulna. Now they forms joints with the lower part of the humerus. Lower part of the humerus is having two portions. One is the capitulum, another is the trochlea. Here they form two different joints. One is the radiocapitellar joint, another is the ulnotrochlear joint. Okay, so in this process, okay, behind there is the olecranon process. This is the coronoid process. Here is the coronoid fossa. So this is just a review of the anatomy. So they forms one joint here. This articular surface of the ulna moves over the articular surface of the trochlea, and here the articular surface at the head of the radius moves over the capitulum and forming the radiocapitular joint. And there are also the proximal radioulnar joints that are also very close to these structures. Okay, so these bony structures are very important for doing the ultrasound, especially at the lower part. Okay, these things needs to be evaluated properly. Why? Because there may be in this area. This is radial fossa, this is the coronoid fossa. This is the coronoid process. So in this fossa, there may be fluid, and because of the effusion, there may be calcification. So this might be there, and that is seen under ultrasound, and that needs to be evaluated. You need to evaluate the radiocapitular joint. You need to evaluate the annular ligament as well. Okay, so these are the things that needs to be checked in the anterior elbow. Now, when coming to the posterior elbow, there is the humerus. Then this is the tip of the olecranon process, and from here there is one muscle, that is the triceps, and this groove is known as the olecranon fossa. Now this olecranon fossa is again needs to be evaluated for fluid, for calcification, etc., etc. Okay, so these are the basic evaluation in the anterior and posterior part. Now coming to the medial and lateral part. So disease affecting the medial and lateral part, the most common are the two epicondylitis. Okay, so what is this? This is the medial epicondyle, this is the lateral epicondyle. So from here, the common extensor muscles takes origin, and that can give rise to lateral epicondylitis when there is inflammation in this common extensor tendon. Similarly, when there is inflammation at the common flexor tendon, the condition is known as, everyone silent? What is the name of that condition? That is the
medial epicondylitis, golfer's elbow.
Golfer's elbow. So these two are very clear, lateral and medial epicondylitis. One is the tennis, another is the golf. So they are related with the tennis. Okay. Now, another thing is related with the, again, there are some noises. Okay. When you talk, you open, and when you are stopping, please mute. Okay. So here there is an important feature. This is the olecranon process, and at the very superficial level, just below the superficial level, there is another bursa. Okay, that is known as the olecranon bursa. And if there is inflammation here, this is known as olecranon bursitis. What is the other name of that bursitis? That is also very common.
Student's elbow.
Student's elbow. Okay, student's elbow. Yes, that is the student's elbow. Do you know any other similar name? Like tennis elbow, golfer's elbow, student's elbow, another type, any other type of elbow?
Pooled elbow. Pooled elbow.
Pooled elbow. Okay, that is for the children. You are now dealing mostly with the adults taking pooled elbow, but there is another time also that is known as the climber's elbow. Okay, so what is that? That is a comparatively rare condition. Today it is a basic course, so we will not be talking much on these terms, but definitely you should know that is another term is there that is known as the climber's elbow. Okay, and the climber's elbow is actually inflammation of the brachialis tendon. Okay, so these are the 4 types of diseased elbow we commonly encounter, among which the most common is the lateral one, next is the medial one. Okay, and student's elbow is quite common, but that is at the posterior olecranon bursa. Okay, the inflammation of the olecranon bursitis. Okay. Now, remember, while evaluating the elbow should be evaluated approximately 5 cm proximal to 5 cm distal to the elbow joint. That is very much important, because if you want to evaluate, these are the structures that help you to find out the diseases, and this evaluation is very important. And the very important tip is that while evaluating the elbow, always first see the clinical condition of the patient, because elbow is a large area. Okay, there is anterior elbow, posterior, lateral. So where you need to evaluate. Okay, so if there is pain in the anterior or lateral side, you need to check that area first. So first we will check what are the things we should go for the ultrasound examination of the elbow. First, take history and examine the patient. So what are the common history? What we ask? First of all, where is the pain? Then how long is the pain? Then what are the postures or what are the movements that increases the pain? Now, for the tennis elbow, what are the movements that increases the pain? Anyone?
Sir, resisted wrist dorsiflexion.
Yes.
Resisted wrist dorsiflexion.
Yes, this dorsiflexion. Okay. And that can be tested with a test. What is the name of that test?
Cosen's test.
Yes, that is the Cosen's test. What we do? Ask the patient and put it on a table. Then we hold this area and ask the patient to move like this. So it will reproduce the pain. And especially for the females, it is not that tennis elbow always occurs to the tennis players or the cricketers. It is very common in the housewives because of the twisting the cloths, okay, after washing. So the patient usually complains, whenever I twist the cloths after the washing, then I get pain here. So that is a very common complaint, and that also signifies the patient is having the tennis elbow. Next thing we need to do is that we should select the areas to be scanned depending on the history. Next, whether we should check anterior, medial, lateral, and posterior, that we need to determine. And it is very important to know that what to see in the anterior elbow, what to see in the medial elbow, lateral elbow, and posterior elbow. That is very much important. So this is the chart that shows what are the important things that should not be missed in the anterior elbow, lateral elbow, medial elbow, and posterior elbow. So what we are going to see in the anterior elbow, it is the biceps muscle, tendon, and its insertion to the radial tuberosity. Okay, but remember this condition, as it is not very common, so today we will not be discussing this very much here. Okay, so and this is at the biceps insertion is a little bit different. So it main branch definitely inserts into the radial tuberosity, but there is a bicipital aponeurosis, and that goes over that is known as the lacertus fibrosis. Okay, so there may be inflammation there as well. Okay, next is we need to evaluate the brachialis muscle, that is the largest muscle. In fact, the most of the areas of the anterior elbow will be able to see the brachialis muscle. Then we need to see the brachioradialis tendon and the muscle. Here will be at the elbow joint, will be seeing mostly the brachioradialis muscle and only small part of the tendon. Next, we need to check the anterior elbow joint. The parts I have already told to you, especially the radiocapitular joint or the ulnotrochlear joint, that part we should need to evaluate. Next, we have to check the median nerve as well. So we will be knowing the home view, or in Kanchan's word, home page view of the elbow here. Okay. Next, coming to the lateral elbow. So lateral elbow, as I have already told, one of the most common problem in the lateral elbow is the lateral epicondylitis or the tennis elbow. So we should be knowing all about tennis elbow because it is very, very basic. We need to know. Next is the radial collateral ligament complex. In fact, they are both very close. You cannot differentiate that this is the exact up to this portion is the common extensor tendon, and up to this tendon is the radial collateral ligament, because they are very close. Usually we assume that at this part of the humerus, the upper portion is the common flexor extensor tendon and the lower portion is the radial collateral ligament complex. Okay, and we need to check that also. If there is inflammation there, we need to check that. Okay, so next we need to go for the dynamic stretching of the common extensor tendon. That is very much important. Radiocapitular joint with the dynamic stretching. These parts are a little bit advanced, so we'll not be taking too much time for this, as it is a basic course. So we'll be checking mostly first two structures. Here we'll be seeing the biceps, brachialis, and anterior elbow joint. These three are very much important. Coming to the medial elbow joint, we need to check the common flexor tendon, that is for the golfer's elbow. Yes, we'll be checking it today, how it looks and how it is different from the lateral epicondylitis, or the structures, how they are different. Then we need to see the ulnar collateral ligament. Again, this part, the deep part of the ulnar collateral ligament, some part I will show. But again, the diseases are a little rare, so I will not be discussing in detail. Ulnotrochlear joint, again, I will be showing ulnar nerve. Okay, so these are the things we need to know. And posterior elbow joint, we need to, very much important is this loose body evaluation. Okay, so this part will be completing today. So first, starting with the anterior elbow, so we need to check the joints. Okay, so this is the radial head. So first, see how the structure looks. Okay, here is the position of the probe. Here I have how I have hold the probe, and here you can see the capitulum. Then you are able to see the radial head. Then you are able to see the brachialis muscle passing over it. And here you can see the smooth surface of the cartilage. There is no fluid. You can see the thin black line. Otherwise, if there is fluid, there will be collection. And big picture I will show when it is inflamed. Okay. And here there might be edema fluid. So more black or anechoic structure you might able to see. Here lies the annular ligament, but for the basic course, it is out of the scope. So I'm not going to discuss much of that. Similarly, if we move our probe towards the medial side, we'll be able to see the coronoid fossa. So here again, we need to check for the calcification. If the calcification is there, we need to see some hyperechoic structures, then fluid around it. If there is fluid associated with the calcification, and here we'll be able to see the coronoid process of the ulna, and this is the trochlea. Okay. Now, Normal coronoid fossa in longitudinal and transverse view. This is usually hypoechoic due to hyperechoic, sorry, due to fat. But when it is inflamed, it will look like this. Okay, so it is the inflamed coronoid fossa. You can see it like this. Okay, so this is the coronoid fossa, longitudinal view with effusion. Okay, so on evaluation, you might need to get this structure. Next, this is the again long axis and short axis view, where we are able to see the some hyperechoic shadows like this. Okay, in short and long axis both. So what is this?
Calcification.
Yes, these are the calcifications. And what is this hyperechoic structures? These hyperechoic areas?
Collected fluid.
Collected fluid. Fine, very good. They are the collected fluid. Now coming to the lateral elbow joint. So lateral elbow, what are the common causes of the lateral elbow pain? They are the lateral epicondylitis, most common, lateral ulnar collateral ligament sprain. There might be posterior anterosseous nerve entrapment, which is the deep branch of the radial nerve. Today I will show you some part of the radial nerve. And when this posterior anterosseous nerve passes through another muscle here, what is the muscle? That is the supinator. Okay, when it is passing through the deep and superficial layers of the supinator, then it might get entrapped there, especially when entering or leaving that muscle. Okay, at that portion, there might be entrapment of the posterior anterosseous branch of the radial nerve, and this condition is known as.
Supinatus syndrome.
No, this is not the supinatus syndrome. This is the radial tunnel syndrome. Okay, RTS. Next, we need to see the radial nerve and radiocapitular joint. So here is the schematic diagram of the same. So here coming the radial nerve. Now it is dividing into an anterior superficial branch and a posterior deep branch. And this is the supinator. When it is entering the supinator, then it might get entrapped there, or when it is coming out from it, it might get entrapped. So that is what is the radial tunnel syndrome or posterior anterosseous nerve syndrome. Okay, so this is the two heads of the supinator, and between these two layers it gets entrapped. Okay, and this is the radial tunnel syndrome. So it is very important to differentiate the tennis elbow from the radial tunnel syndrome. Remember, as this is an inflammatory pain, so the most of the characteristics of the pain will be nociceptive type of the pain unless it is very chronic. Whereas in radial tunnel syndrome, the cause is the entrapment of the radial nerve. So it will be more of a mixed or neuropathic variety of the pain. And the radial tunnel syndrome pain comes down towards the distribution of this nerve, whereas the tennis elbow usually restricted here. Okay, and with the supination pronation, this pain, radial tunnel syndrome pain, will be increasing because it is going between the supinator. So that is how you need to differentiate the structures. Okay, so let's see how to position the hand in the lateral elbow ultrasound. So patient will be usually supine. Put a pillow below the put a pillow below the elbow. Then you need to check the structures here. Okay, so that is the hand positioning for the lateral elbow ultrasound. Now, what we need to see? We need to see the common extensor tendon, radial collateral ligament complex. Other things I am not going for today. So this is the structure. This is my hand drawing, not great, but understandable. So what you need to find out? So we need to find out the lower lateral part of the humans. Okay. So here, this is the lateral epicondyle. Now, the slope coming from the lateral epicondyle, there will be able to see these fibers. The fibers above or fibers close to the lateral epicondyle is the part of the common extensor tendon. Usually it is considered the whole length of the fiber, the upper 50% is by this common extensor tendon, and the lower 50% is composed by the radial collateral ligament. So there might be a radial collateral ligament sprain or an inflammation in the common extensor tendon. Okay, and here you will be able to see the common extensor tendon is actually being continued as the muscle, okay, because tendon is the end portion of the muscle that attaches with the bone. So here this structure we will be able to see, and below that we will be able to see the radial head, and here there is the annular ligament. Okay, I'm not going to details of the annular ligament, but we will be able to see it here because knowing the structures is very much important. Now coming to the, if the you are suspecting a lateral epicondylitis, what are the diagnoses should be considered? So I have already told this. First of all, posterior interosseous nerve compression, sometimes confused with the lateral epicondylitis, radiocapitular arthritis, cervical radiculopathy. Yes, this can be confused with the lateral epicondylitis or radial tunnel syndrome, because if it is along the C5 or C6, then mostly the C6, there might be pain here. Okay, so that is very much important, and also you need to know that cervical radiculopathy, inflammatory arthritis, and myofascial pain. So these areas needs to be evaluated properly. Coming to the medial elbow joint. Okay, for the medial elbow joint evaluation, this is the hand position. So forearm to be pronated, position in the external rotation and extension or slight flexion. So that's how to evaluate the medial elbow joint. Next, what we need to see in the medial elbow joint, we need to check the common flexor tendon, then ulnar collateral ligament, ulnar trochlear joint with dynamic stressing, and the ulnar nerve. These things we need to check here. Okay, so this is the picture of the medial elbow joint. Again, not great, but you will be able to understand this schematic diagram. So here, when we see, what we do is that we actually check the medial epicondyle. Okay, and then from the medial epicondyle, we are able to will be able to see the common extensor tendon, sorry, common flexor tendon, and below part will be the ulnar collateral ligament. If we compare with the common extensor tendon, this tendon is thick and more stout, and usually here we need to slightly angulate our probe to check these two structures, that is the ulnar collateral ligament and the common flexor tendon. They are not always at the same plane, so we need to slightly change the direction. Okay, if you want to see the deeper fibers, then we have to go back slightly the posterior fibers. Next is very much important to evaluate the cubital tunnel, because cubital tunnel syndrome is also a very important area. And when this ulnar nerve is going through the cubital tunnel, okay, here when it is going to the through the cubital tunnel, it may be compressed there. Okay, so what are the structures that actually compresses it? So first of is the Osborne's fascia. So what does the Osborne's fascia do? From medial epicondyle to the tip of olecranon process, this is actually a band-like structure here. Okay, so this fascia, when it is deficient, okay, it might cause subluxation of this nerve over the medial epicondyle. And remember, in this area, this nerve usually appears hypoechoic. Okay, we all know that nerves appear sometimes honeycomb, sometimes hypoechoic, sometimes a little honeycomb plus hyperechoic, depending on the surrounding structures, how the surrounding structures is. Okay, so if you see the medial nerve here at the proximal part, at this area, okay, you will be able to see the nerve hyperechoic and honeycombed. The same medial nerve, if we go towards the tendons here at the level of the wrist, it will see it hypoechoic. So depending on the echogenicity of the surrounding tissues, you might see the nerve in different echo textures. So it should be remembered, it will be hypoechoic here. So tips for the dynamic testing. This dynamic testing is not a very basic thing, so we can skip that. Now coming to the posterior elbow. So what are the things we need to check in the posterior elbow? In the posterior elbow, we need to check the triceps first. Okay, we'll be able to see the triceps. Its two heads we will be able to see joining with the triceps is having three heads, but here we will be able to see only two heads actually joining to the olecranon. Next is the posterior elbow joint. Okay, we'll be able to see, and here we will be able to see the olecranon fossa, practically posterior elbow joint, and we need to evaluate for the loose body and ulnar nerve again in the posterior medial part. So I have covered it in the medial portion of the shoulder. So this is how it looks in the posterior elbow. Okay, so here it will be able to see the tip of the olecranon. We will be able to see the humerus. Now, if the patient is having student's elbow, it is a very common condition. So what we will be able to see? We will be able to see fluid superficial to this triceps. Remember, student's elbow is superficial to triceps. It is not deep. Okay. So in those cases, you'll be able to see the barsal fluid. Okay. So this is the normal. See the triceps here. Okay. This is the fat pad of the olecranon fossa. So if there is inflammation in the olecranon, you'll be able to see fluid here. If there is the student's elbow or olecranon bursitis, see this is the picture of the olecranon bursitis. Here, this is the triceps, and you can see superficial to this structure, there is barsal fluid, and that is the olecranon bursitis. So that was all about the basic ultrasound evaluation of the elbow. Next, I am going to demonstrate, but before that, if you have any question, let me answer that.
Hello, excuse me.
Yes.
Please, what are the names of the joint diseases in the elbow? The different names of different diseases.
Different name of different diseases. The disease
Yeah.
I have told. Okay. So I have told you 4 diseases. One is the lateral epicondylitis. That is the tennis elbow. Another is the medial
Tennis
epicondylitis.
elbow. Okay.
Tennis elbow. Yes.
Okay.
Then medial epicondylitis. Sorry, I am showing it. It is not shown actually. Okay. So this is the lateral epicondylitis. This is the medial epicondylitis, and this is the golfer's elbow. Okay.
Golf?
Now, golfer's elbow. Golf
Yeah.
playing. Okay. The golfer's
Okay.
elbow. Okay.
Okay.
When there is inflammation at the fluid at the tip of the olecranon, that happens to the students because of the writing. Okay. So that is the student's elbow.
Students.
And when it happens here, okay, at the brachialis tendon, that is known as the climber's elbow. But again, it should be remembered that brachialis tendonitis is known as the climber's elbow, but it is an uncommon disease. Whereas the common, what happens to the climbers is not the climber's elbow. It is the golfer's elbow. That is the commonest to the climbers. But brachialis tendonitis is typical, specific to the climbers. That is, it is known as the climber's elbow. Okay, don't get confused.
Thank you.
Okay?
Thank you.
Get clear that climber's elbow is actually brachialis tendonitis, but for climbers, the commonest problem is the golfer's elbow. Okay. So let's start evaluation. Any other question?
Sir, position for the posterior elbow examination.
Okay. Posterior elbow examination positioning is almost like the lateral elbow. Okay. So we will be putting the arm like this. Then we will be putting our probe here. Okay.
So you mentioned four elbow, golfer's elbow, tennis elbow, and
Hello. Okay. Okay. Please unmute.
hello.
Yes.
One golfer's elbow, another tennis elbow, another climber's elbow. You mentioned one elbow, fourth elbow.
That is
Please
student's
mention
elbow. Student's elbow. That is very common. Okay.
student's elbow.
That is the
Please
olecranon bursitis.
Olecranon
Olecranon bursitis. Okay, I have shown that now. So I have shown you the picture of the student's elbow, the ultrasound finding of the student elbow. See here at the last slide, I have shown you the student's elbow. Okay, so this is the So this is the barsal fluid at the student's elbow. Can you see this? Here you can see the barsal fluid.
Yes.
Okay, so this is the student's elbow. See, here is edema fluid. Okay. Okay.
Thank you, sir.
Any other thing? Any other questions?
Please show the picture and video.
Hello.
Elbow.
Yes.
Video. climber's elbow, please.
What is the, okay, one question is asked, that is by the Dr. Priyanka Singh, that is what is the name of the test? Resistance against the disc dorsiflexion, that is known as the Cosen's test. Oh, already someone has answered. Okay, so that is the Cosen's test. And what is the answer? Wrong query, I could not find this. Okay, okay, so
Excuse me, Cousin test is for which disease? For which Cousin test?
Cosen's test is for the lateral epicondylitis of the tennis elbow. Okay, the test is like this. You should ask the patient to put on a hard surface like this, or you can support it from your other hand. Then you put resistance here. Okay, with the other hand you put resistance, and now ask the patient to move the arm like this.
Okay. Any other test for the elbow?
What?
Any other test for elbow?
Any other test for elbow? Okay, there are a lot of specific tests, but this is the commonest test we need to know. Okay, rare things today we are not discussing, like the climber's elbow. Okay, climber's elbow detail I have just mentioned you the name because you should know, but it is not very common, and right now I don't have a video there for the climber's elbow. Okay, so I cannot show that. Okay, it is a very rare condition. So rare and uncommon conditions we are not going to discuss much. Okay, just you need to know the name, that this disease is there. Okay, so now I am going for the ultrasound evaluation in the volunteer. Chalo. শুয়ে পড়ো এই চায়ের কাপ পড়ে যাবে, ছোট চাটা একদম বাজে আছে। এটা অন করাটা অফ হয়ে গেছে, এটা অন করা নেই। কানেকশন লুজ আছে, সুইচ অন করা হয়নি, তাই তো? ওকে, আসেনি, ওটা আসবে, এটা আসেনি বলে আসেনি। হাতটা সোজা করে রাখো। ওটাকে একটু না সামনে থেকে ওই দিক থেকে উপরে বসে উপরে তুলে দাও, না উপরে তুলে দাও, উপরে তুলে দাও, ভাঁজ করে উপরে তুলে দাও। তোমাকে একটু নিচে বয়ে আনতে পারবে না, না আমার করতে, ঠিক আছে, হয়ে যাবে, কিচ্ছু হবে না। চুলটা সরো, চুলটা দাও প্লিজ। So today first we are taking this probe, that is the linear probe, and we are putting the jelly now. How to start? We need to start from the lower part of the humerus, then it is easier. Can I see the probe? But it is difficult because you are seeing more of my hand. So I am holding in like this. So this is how you should start. So I have not done anything. I have not done anything. I have just put the linear probe. And now you are able to see one bone at the lower portion. All right. So this is the lower portion of the shaft of the humerus. Now we will come to the our home view. So we are coming down. As we are coming down, then the bony contour changes. So I'm coming again, because here also it's very important to note also. Here the depth was much more. Remember, the bone is behind the brachialis and the biceps muscle. Okay, if we go further, we will be seeing more of biceps and less of brachialis. If we go below, we will be seeing more of brachialis and less of biceps. And biceps, see, big muscle here, but when we are coming down, biceps will become a small tendon. Can you see the biceps, the upper part? Here, you can see almost 50% biceps and 50% brachialis. As we are coming down, biceps is becoming narrowed to only a tendon. Okay. And when we are coming down, we are able to see this curvilinear margin of the lower part of the humerus. Now, the left part of the screen, what I am showing it, it is the lateral part of the patient, or lateral part of the elbow. So once we are getting this structure, then we need to reduce the depth so that we can see a larger portion. So now we are able to see a larger portion of the bony structure. So now this part I am reducing the focus also. Sorry, chroma. So now you are able to see this bony portions. So here I want to show you the exact bony structures, what is there. Okay, let me stop here. So this left-sided, what Dr. Roy is drawing, this portion, this left portion is the capitulum portion. And the right portion, you can see on the screen, this is the trochlear portion. Now, if we check this left portion, first I am describing the bone only. So if we check this left portion, then we'll be able to see, first we have already seen in the cross-section short axis view. Now we are taking that at the center and we are rotating the probe in such a way that 90 degree, all right, so that we can see the portions of the trochlea and the head of the radius. So as we are coming down, here the rounded structure, okay, we need to readjust the timing and compensation so that we can see better. So the left portion of the screen is proximal, the right portion of the screen is distal. So we have increased the depth to make it more clear for you. Then we are reducing the frequency as well. Now we are coming down. Now slightly more down, then you will be able to see this bony structure. This is the anterior portion of the radiocapitellar joint. So in this radiocapitellar joint, above rounded structure, that means the structure towards the left side of the screen is the capitulum, and right side of the screen is the radial head. And here, this is the area of the joint that you need to concentrate. In this area, I have shown you fluid previously in my lecture, and I have shown you the calcification. But as this is a volunteer, so there is neither fluid, neither calcification. So this is normal. And this muscle above what you are able to see is the brachialis muscle. And this is the head of the radius. And as I have told, will be annular ligament. This is the annular ligament just below it. So this is the classic picture of the radiocapitellar joint. Sorry. Okay. No, this is not radialis. Radialis is much lateral. Okay, this is brachialis here. Brachioradialis, I will show them brachioradialis as well. Now we are again coming to our home view or home page view, whatever you call it. Okay. So again from that, again I'm back to the home page view or home view. Now we have focused over the capitulum. It's time to focus over the trochlea. So we are the classic ways make the structure you want to see in log axis at the center. So you have put the this trochlea portion at the center. Now again I am doing the same thing. I am rotating it 90 degree. Okay. So here we will be able to see. Okay. So I am to increase the depth slightly. Okay. So that you can see it up. So let me zoom a little also. Okay, fine. Okay. Depth. Okay, so there are some anisotropy of the fibers here, and here you can see the capitular cartilage at the left side. Clearly, you are able to see the capitular cartilage. So I am freezing here. Okay, so sorry, not capitular. This is the trochlear cartilage. So here is the trochlear cartilage, and here you are able to see that joint. Okay, this is the coronoid process, and here you are able to see the joint portion. Now, again, I am focusing that. Okay, and now if we move up, so I have moved up. Here you can see the fossa. So this one is this area you are able to see the coronoid fossa. So if there is fluid, there is calcification, we will be able to see at this point. It is removed. Who has car call chile? That's the unknown number. I will check later. So disconnect করব কি করে মাঝখানে okay let's try to disconnect মোবাইলটা অফ করব এই বন্ধ হয়ে যাবে আমাকে তাহলে এটা আচ্ছা করেই নিই মোবাইলটা okay fine ফোকাসটা কিরকম ছিল fine let's zoom a little. Okay. So here we can see the coronoid fossa. So the anterior bony structures of the joint is clear to everyone? Hello?
Yes, sir.
Okay, fine. So next we are moving to the other structure. So again, I am keeping the aspect marker towards the lateral side of the patient. So left side of the screen will be the lateral portion of the joint. Okay. Again, we are coming to the our home view. Now we are zooming out, and here we will get to know the muscles. So again, we are stopping. So what is this big muscle in front? What you can see? Big muscle. That is the brachial.
Hello, excuse me. Sorry.
Yes.
Please, you will tell us later where are the sites for injection for elbow?
Okay, I will show you. Okay. So don't
Okay.
first know the anatomy. Okay.
Okay. Thank you.
So I will show you the videos and show you that also today also only. So now we need to know the important structures. Here you can see the brachialis. Now from the brachialis, देखिए दिया आगे ब्रोशन मसल्स को देखिए देना. If we go to the lateral side, the muscle changes. This is the junction of two muscles. Okay. So this was the brachialis. Now, when we move to this portion, the muscle at the left or the lateral side is the brachioradialis. All right. So here we are able to see the brachioradialis, and in between these two muscles, there is another very important structure. Okay. Let's try to find out that. Okay. So I am showing it a little from it a little bit proximal. Okay. So can you see a slight hyperechoic honeycomb structure in between these two muscles? This is slightly proximal. Then this I am coming down. Then you will be able to see this structure dividing into two. Okay. First, try to note the interface of these muscles. Okay. So this is the brachialis, and the left side, this is the brachioradialis. After trachea. না এটা দেখিন একবার টাইম নিয়ে ফেলবো করতে হবে. So here you note, and when I am following that nerve, okay, in between where you are able to see, okay, this is the nerve. I am showing with the cursor. Here is the nerve. Okay, here is the nerve. Okay, so you might see 2-3 branches here. Okay, here above you will be able to see one. As we come down, it will surely divides into two. Sometimes you are able to see 3 branches as well. Okay, now you are able to see 1 branch and 2 branch. Okay, 2 branches. This is one, this is another. And as we come down, 1 branch will come here. In between this is the supinator muscle. This is the supinator muscle. So in between this supinator muscle, here 1 branch is going. Okay, so now it is dividing into the superficial and deep portion, and here there is the nerve. Okay, so this is the posterior interosseous nerve. So if there is entrapment, we need to inject here at the nerve. Okay, so that was about the radial nerve. Now what about the other structures in this picture? So here you are able to see another muscle at the medial side. Okay, that is comparatively hypoechoic in relation to the brachialis, and this is the pronatractidis muscle. And what you are able to see is the interface or the junction between the brachialis and pronatractidis. Now hypoechoic, yes, hypoechoic. Okay, see, I'm talking it over. It is hypoechoic muscle. Okay. Now I have taken much medial, so you can see some fibers inside as well. That is the pronator teres. And here, if we release pressure, you will be able to see one artery, and that is the brachial artery. And just by the side of the brachial artery, you can see another honeycomb structure. So let me do one thing. As it is superficial structure, so we are moving the focus up. Now you can see this honeycomb structure very clearly. This honeycomb structure. Can you see this? Just by the side of the artery. So what is this structure?
Median nerve.
Yes, that is the median nerve. Fine. And here we will be able to see one tendon. Okay, as see, if we are not able to find out that the tendon, just move up, then we will be able to see the muscle. So this is the muscle. As I am coming down, the whole muscle is getting into a small tendon. So this is the tendon. Okay, this is the biceps tendon. Okay, and it goes to attach to the radial tuberosity. Now, if we want to see the biceps tendon in longitudinal view, again we should apply the same formula. There is nothing different. So first make it at the center, hold the probe, rotate 90 degree. Okay, so what you are able to see, the longitudinal view of the biceps tendon. Now if we go down, so the below muscle is brachialis, above is biceps. Here you can see a little bit of anisotrophy in the lower part. Okay, to reduce the anisotrophy, what I am doing, I am just doing a little bit heel to maneuver so that it becomes a little clear. And to see the deeper part, we need to increase the depth of the focus also. Okay, then we will be able to see it is attaching to the radial tuberosity. Now you can see the radial head. So this portion is the radial head. Now if I ask the patient to pronate and supinate, okay, so pronation hatta ghorao. Okay, see the tendon is also moving. Okay, as it is related to pronation and supination. Okay, we will pronate now see the sweeping down portion of the brachialis tendon is actually moving with the pronation and supination. So that was the important structures in the anterior elbow. And here it completes the examination of the anterior elbow. After the anterior elbow, we are going for the lateral elbow examination.
Excuse me, sir.
So,
Sir, can you please show again the radial nerve and neurovascular structure of the anterior view? Anterior
okay,
elbow.
fine, I am showing it. So when we are coming to our home page, or this is the home view. So this is the brachialis. Now, fix artery dekhte pabe na. So can you appreciate the artery? Can
Yes,
you
sir.
appreciate the
Yes, sir.
artery?
Yes, sir. Yes.
Okay. So তুমি চলন্ত অবস্থাতেই ছবি আঁকো, কোনো অসুবিধা, হাত মুভ করছে না। Now if we reduce the focus to up, then it is close to the nerve. Now can you see the nerve? Just by the side of the artery. This is the nerve. This is the median nerve. Next, here can you see two superficial and deep branches?
Yes, sir.
This is the brachialis. This is the brachioradialis. In between, you are able to see the superficial and deep branch of the radial nerve. This structure is actually the tendon of the brachialis. It starts actually myotendinous junction. So some part of the tendon you are able to see. Don't confuse it as a separate muscle. This is the same muscle, brachialis. So this is seen, this part shows triangular and this part shows something like oval, but this is the tendon inside the brachialis muscle. Do not consider this as a separate thing, okay? And here, they are the two parts of the radial nerve. So, is it clear?
Sir, also the PI now.
So, one is superficial, one is deep. The
Nee,
deep
nee.
part is the PIN. As we follow the deep part, see, this is the deep part. Okay, so it will come down and ultimately see, this is coming down and this will come within the supinator. Okay, so can you see the supinator muscle? This is the supinator.
Yes, yes.
Okay, and here is the nerve. It has come inside the supinator. So that we need to know here. All right, first. So this is the anterior elbow. Now we are going to the lateral. So for the lateral, we are changing the position of the patient. And now we are putting the gel. And here, first thing we need to do is need to palpate the lateral epicondyle. So this is the lateral epicondyle. And after palpating the lateral epicondyle, put the probe over the lateral epicondyle. All right. So now we are able to see the lateral epicondyle and okay. Again, it's a superficial structure. So okay. So it's not clear. So focus up. We need to change the frequency as well. Okay, as it is a superficial part, so the frequency we need to increase. So we are increasing the frequency. Now here, as we are putting it, okay, so we are able to see this hilly structure. Okay, so left side there is the okay. Now it is fine. Okay, can you see the hill? And from which it is coming down towards the joint. Okay, let me stop it. Okay, so this is the bone, and here you can see it is coming down, and here it is the capitulum, and this is the head of the radius. So this portion is the common extensor tendon, and in this attachment, the superficial part is the common extensor tendon, and deeper 50% is the portion of the radial collateral ligament. So again, I am showing it to you. So here you can see the common extensor tendon, and as we are moving more towards the okay, see, now we are over the radial head. Okay, make it superficial. Okay. Okay, so now we are over the radial head, and you can see the radial head, and you will be able to see the joint as well. Okay, so this is the joint in between. Okay, so when I'm holding like this, you'll be able to see the joint from the lateral side. Okay, so this is the again coming to the
Excuse me, sir. Can you show
Okay.
the orientation of the probe in relation to the patient's hand?
okay, so can you see? Okay.
So
So this is the orientation. Okay. Hand is like this, and this is the orientation. Fine. Can you see the seat, the probe? It is seen. হাতটা দেখো না, হাতে প্রোবটা দেখো না, হাতে প্রোবটা দেখো না, প্রোবটা পরিষ্কার আসে না তো। আজকে না। Can you see now?
Yes, sir.
Yes.
Thank you.
Okay, so from this is the lateral epicondyle, and here from here the muscles are going to the extensor compartment like this. Can you see my hand? So it is muscles are going. So we need to put it in that direction only. Okay, so this is the aspect marker. We are putting it over the lateral epicondyle and the probe like this. And from when we are holding like this, again, any confusion, just palpate. Okay. Okay. So I have taken it medial. I to push a but this is clear. So first part is the common extensor tendon and the lower part is the radial collateral ligament. Is this all right? So now when you are going to inject, then if you are injecting PRP, then remember the most commonly nowadays we prefer PRP here rather than the steroids. So when you are injecting PRP, you can give in the tendon, in the portion of the common extensor tendon here. Okay. And when we are injecting steroid, that is, remember, you should give either below near the muscle, or we need to give to the side of the tendon, not inside the tendon. Okay. Steroid should not be given inside the tendon, either within the muscular part or it should be given around the tendon. That is important. So next, I'm going for the medial elbow portion. Medial elbow, again the same thing. We need to palpate the medial epicondyle first. Okay, so this is the medial epicondyle. Now we are holding the probe and flexor muscles are coming like this along the direction of the common flexor tendon. So now here you are able to see the medial, here it is a stout. Okay, these fibers are much stout. See, this area is the common flexor tendon, and the below portion, lower portion, this is the joint, and here some part is formed by the ulnar collateral ligament. Similar way, but here, as I have told, they are not at the exactly same plane. Okay, in this portion, you are able to see more of muscle. As we move the lower part of the probe slightly towards the posterior side, then we will be able to see the more of the tendon portion. Sorry, more of the ligament portion. Okay, so they are not exactly at the same plane. So that is the difference with the. Okay, now you are able to see a little more portion of the ligament. So that was all about this part. Now we'll go to the cubital tunnel. Okay, again for the injection, the principle is the same. Okay, so if you are injecting the PRP, we can go inside the muscle. If you are injecting the steroid, then we should give either inside the muscle or around the tendon, not inside the tendon. Okay. Now, if we go farther down, okay. So if we go farther like this, then you are able to see the more of the medial joint, and you are able to see the more of the ulnar collateral ligament. Now, here I am moving up, and now I am putting the probe bridging two structures. Okay, one is the medial epicondyle, another is the olecranon. So this is the medial epicondyle, this is the olecranon. So what I am doing, I am putting the probe, I am using a little bit jelly first, bridging these two structures, that is the medial epicondyle and the olecranon. So we are putting like this. So here at the left side of the screen, you are able to see the medial epicondyle. As I put the aspect marker towards the medial epicondyle and the opposite side towards the olecranon. So here you see clearly, okay. So clearly let me focus first properly, okay. So again, we are trying to get superficial and we are increasing the frequency. Now, if we hold it properly near the medial epicondyle, can you see a hypoechoic structure? This is very clearly visible here. Draw করে দাও। That is the hypoechoic structure. Okay, this is the hypoechoic structure here. So what is this hypoechoic structure?
ulnar nerve.
Yes, very good. This is the ulnar nerve, and this what you can see above this white line is the Osborn's fascia. Sometimes it is known as the Osborn's ligament or retinaculum. There are slight difference in these terms according to studies. Okay, some studies says in this part Osborn's retinaculum and below Osborn's ligament, but they are the same structure and they are in continuation. So consider it as Osborn's fascia. So if it is deficient, then this nerve might move up and there might be entrapment here. Okay, and that is known as the cubital tunnel syndrome. Now we are coming to the last part or the posterior part. Okay, we have 1 hour left. Okay, so we have enough time now. So for evaluating the posterior part, what position we are taking, we are asking the patient to do this. Okay, here we are holding the probe like this. Okay, so the aspect markers towards the proximal side, and we need to here have to go slightly deeper, so we need to increase the depth here. Yes. Okay, so here we need to focus properly. Actually, the problem is the depth is much superficial, so we need to focus down, down, down. Now you are able to see a beautiful picture. Okay, I'm reducing the frequency a little also. Okay, no, 13, 10, around 10. Yes. Now you are able to see the clear view of the triceps and olecranon fossa. So here, this portion is the olecranon fossa. This is the tip of the olecranon, and this is the triceps. Okay, this is the triceps. This is the muscular part, this is the tendinous part. Ultimately, all are becoming tendon here, and they are joining at the tip of the olecranon. So if there is fluid, you will be able to see it here. And here we can see slight fluid, but that is normal, that is not abnormal. You are able to see the fat here as well. And here you are able to see the triceps. And if there is fluid here at the level at the superficial area, this is the student's elbow. Then we will be get the fluid here. So if there is fluid here in the olecranon bursa, we will be able to see here. And if there is fluid here, that is a student's elbow, you will be able to see here. The same structure we can appreciate in the short axis view. Now we are starting from the tip of the olecranon. Only a small portion you can see. As it is a pointed structure, you can see the pointed tip of the olecranon as we are moving down. Okay, as we are moving down. Okay, so let me hold it properly. So here you are able to see the olecranon fossa in the short axis view. So you can see only fat, and here you can and here you can see the two heads of the triceps, they are joining together. Okay, so ultimately they are joining to the same tendon. As we go, we will be able to see more of triceps. And here they are all becoming a tendon and they are becoming joined at the tip of the olecranon. So that was all about the elbow examination part. Then I will be going for the intervention part. So before the intervention part, anything you want to ask?
Sir, is student elbow and olecranon bursitis the same, or there are different levels?
It is the same. The student's elbow is the olecranon bursitis.
Okay.
Okay, like tennis elbow, it is the lateral epicondylitis. Same. Okay. So next we need to show you the intervention video. So that is the elbow joint intervention. Okay, we have time today. Enough time is there. So, no, not come. Share. Yes. So now we'll be going for the common ultrasound guided intervention for the elbow joint pain. So I'm not going into the history of the patient, that part I'm skipping because of time, but PRP injection for the lateral epicondylitis. So this is the history of the patient. So basically this is a surgeon's history with pain continuously. Yes, laparoscopic surgeons are very prone to this condition, okay, because they have to hold the equipment like this for a long time, okay. So here, after the preparation of the PRP, so we need to first give the local anesthetic injection. Next, under the ultrasound, here, as I've already shown you, this portion is towards the proximal, this is towards the distal. Now we are entering with the needle towards this portion, to the lateral epicondyle, okay? That is like this. Now, here, the needle is very close to the lateral epicondyle, like this, and after that, PRP injection is being done. So this is how we go for the PRP injection, okay? Next is the ultrasound guided corticosteroid injection for the posterior elbow pain, inflammation at the olecranon fossa. So here, again, you can see the fluid in the olecranon fossa on the examination, okay? Previously, you have seen the olecranon fossa, now you see the olecranon fossa, okay? So there is a lot of fluid here. So here is after clinical examination. So first needle is put here, and after putting the needle in the olecranon fossa, cortisone injection is given here at the olecranon fossa. If the fluid is more, you can do another thing. You can first aspirate the fluid and then inject. Okay, so this is post injection. Okay, so that is the injection at the olecranon fossa. Next is the corticosteroid injection for the anterolateral elbow pain. That is the pain due to inflammation at the radiocarpal arthritis. Okay, so radiocapitellar joint, as I've already shown you the radiocapitellar joint, here you can see the radiocapitellar joint is having the fluid here. So here again, after the preparation, we are entering the needle towards the radiocapitellar joint. Now here is the radiocapitellar joint. Again, we need to go for the aspiration and then we need to go for the injection. Okay, so this is the joint after injection. Next, ultrasound guided corticosteroid injection for radial tunnel syndrome. Here, as I've already shown, how to look at inside. Okay, see, this is the inside the, just let me stop. This is the supinator and this is the nerve in between the superficial and deep layers of the supinator. And now the needle is being done. So like all intraepiduropathies, first we need to give the injection up here. And then we need to first make a halo sign, that will be fluid above it. And then we need to put the needle below. Okay, and then we need to inject fluid from below also. So that is the injection for the radial tunnel syndrome. So that was the common injections for the elbow. Okay, so if you have any question in the elbow, you can ask me. Otherwise, next I'll be moving for the examination of the wrist. Okay, so there is some questions in the chat box. Okay, you have given answer, na? Any other question you want to ask?
Yeah, please can you summarize the injections for elbow? How many injections we have?
Okay, actually, if you see the number of injections is much more. I have shown you 5, but common injections I have shown at the olecranon bursa. For the olecranon bursa, it is student's elbow injection I have not shown, but you can give the student's elbow injection commonly. Then I have shown at the radiocapitellar joint. I have shown for the radial tunnel syndrome. Okay, actually whatever photographs we have or videos we have, I have shown that. But there are other injections as well, like the golfer's elbow injection, tennis elbow injection. Tennis elbow I have already shown, and injection for the brachialis aponeurosis also. Okay, so that part I have not shown because I don't have the video. So, and that is not common also. For the basic course, I think this bicipital tendinosis inflammation is, I think you can skip. So that are the common injections we perform at the level of the elbow joint. Okay, all depends on patient. Next, we are going for the, okay, let's stop this and we need to go for the wrist joint. Where's the wrist and hand protocol, hand basic. Okay.
Sir,
So-
how much time should we wait before the injections we do in the elbow? Like before giving an injection, how much time
Oh.
should we wait?
It is not how much time to it, but it depends on how it is responding. If it is responding with the conservative management, so always we say conservative management is first. If it is not responding with the conservative management, then we should go for it. Okay, so usually we try depending on the symptoms. If it is responded with the conservative management, then it is fine. If you are getting relapse with the conservative management, that means you are giving NSAIDs or you are giving the steroids for some duration, and then also if the pain is coming back, then we should consider giving PRP for those patients. But remember, usually for the steroids, we need to keep a gap for up to 2 to 3 weeks between the injections. If you are thinking of the PRP and you have used the NSAIDs, that is with up to 1 week. If you have given the depot steroids, up to 3 weeks. If you have previously used the only oral steroids, then again 1 week. Before that, we cannot give BRP. But if you want to inject the steroid, depot steroid here, then we can inject immediately when it is failed. And also, it's to be remembered, there are some patients who are not fit for the medical therapy, like the patient of CRF. So in those cases, you can give early. Okay, all depends on the patient condition.
Okay, thanks a lot.
So the wrist and the hand USG protocol for the basic. So here the learning objective is, so you will be able to know the common anatomy and anatomic conditions and painful conditions of diseases of the wrist and hand. So here mostly we are going to cover the common conditions like CTS, like the decubitus tenosynovitis and the trigger finger, these 3 areas. So let's start with the ventral wrist ultrasound. So for the positioning, usually today the patient we have already set for the elbow, so we will not be setting again for the wrist. So we'll be doing in the patient in the supine position. But for the wrist, usually in most of the cases, we do while the patient is sitting. We put a hand in the table and we sit at the opposite side of the table, put a towel below the wrist, and so that wrist is a slight extended like in this position, okay, like this. Then we will be examining the ventral portion of the wrist. Patient should be comfortably sitting opposite side of the table, folded tag below the wrist. Now, this is very common thing you know from your undergraduate days. She looks too pretty, try to catch her. Okay, so what are those? Or you can say she likes to play, try to catch her. Okay, anyway. So scaphoid, lunate, triquetrum, pisiform, trapezium, trapezoid, capitate, hamate. Okay, so this order should be remembered. Okay, so if we see at the proximal column, so we have 4 bones. What are those? Most radially, the scaphoid, then the lunate, then the triquetrum, then the pisiform. Okay, and here the most prominent bone what we get in the proximal carpal tunnel syndrome is not the scaphoid, but it's the lunate, and it is the tip portion of this lunate is slightly superficial to the other bone, so we will be able to see a prominent lunate bone. Okay, and then in the distal part we have 4 bones. Okay, what are those? Trapezium, trapezoid, capitate, hamate. Okay, now here in this portion we will be able to see a prominent hook of hamate. We will be able to see a pisiform as well. Now if we divide it from, that division is from the short axis view, but in the long axis of the hand, if we try to divide, then we will be seeing three bones together. That is, in the lateral side, you will be able to see the scaphoid, so scaphoid, trapezium, trapezoid, and in the lateral portion, triquetrum, pisiform, and hamate, and the center, the capitate and lunate. Okay, pisiform is the regarded as a sesamoid bone embedded in the tendon of the flexor carpi ulnaris. Okay, so this is the how it looks, because here in the drawing that all the things are made much clear, but the bones are not that clear. They overlap, some overlapping of the one over other, like the trapezium and trapezoid. You can see the overlapping here. Similarly, you can see the capitate here, you can see the hamate here. This is the hook of hamate, and here you can see the scaphoid bone, you can see the lunate bone, you can see the triquetrum, you can see the pisiform. Okay, so you can see the pisiform and hook at hamate here. You can see the lunate here, that is the most prominent bone I have already told. Here is the triquetrum. Okay, so that is how the bones are there. Okay, so if we read only and then try to see, you might not be see the bones properly. Next, how it looks in the ultrasound. So it all depends, like X-ray, all the bones you can see at the same section or in the same plate. Here you cannot see in the same plate because they are showing the short axis cutting views. So it depends on how many bones we'll be seeing, will depend on where you are cutting. Okay, so this is the probe is held here. So you can see the capitate, sorry, scaphoid, you can see the capitate, you can see the portion of the hamate, you can see the portion of the triquetrum, and you can see the pisiform. So in this level, you are able to see 5 bones. But if you go slightly proximally, then we will be able to see only 3 bones. That is the scaphoid, then a prominent lunate, and the triquetrum. So remember, when we are checking the carpal bones, we should check along the proximal to distal or distal to proximal to note all the bones, because it is not that at the same plane you are able to see the pisiform. Okay, so we have read that there are 4 bones in the proximal row, so we will be able to see at the same time, but it is not the fact. Okay, so but remember, for the basic course, only if you can identify this bone, scaphoid, and pisiform, that's good enough for our procedures. Okay, lunate, because this is one of the very important landmarks what we find out in most of the procedures. Then scaphoid and pisiform, because there is a transverse carpal ligament between these bones. The transverse carpal ligament is very much important for the CTS. So this is the cross-sectional view. So what you can see in this cross-sectional view, again, depending on where you are cutting, you will be able to see the carpal bones. Next, what you will be able to see, from the scaphoid to the pisiform, you will be able to see a ligament, that is the transverse carpal ligament. And below this transverse carpal ligament, we will be able to see the median nerve. And superficial to this ligament, we will be able to see the ulnar side, you will be able to see the ulnar nerve and ulnar artery. Okay, and here we will be able to see the tendons of the flexor digitorum superficialis and flexor digitorum profundus. They are together. So to separate from the median nerve, what we need to do, we need to ask the patient. So if you are expert enough, then you will be able to see and meet the median nerve and you will be identify. But if you are not, ask the patient to move the fingers like this. So what will happen? All the tendons will move, but not the median nerve. That is how we will be able to differentiate the median nerve. Only inside, but slightly separate, we will be able to see the flexus pollicis longus tendon and flexor carpi radialis. We will be able to see outside this. Okay, outside the this transverse ligament. Palmaris longus tendon usually not that clear on ultrasound. Okay, so here you can see the pisiform bone. Here you can see the scaphoid bone, and in between this pisiform and scaphoid, this is the transverse carpal ligament. Okay, and here is the median nerve. So here you can see the ulnar artery and nerve. Okay, at the ulnar side, this is the transverse carpal ligament, and you will be able to see the ulnar artery and nerve here. Okay, this portion is the artery. Okay, this is the artery shown in the red, and this portion is the nerve portion. Okay, shown in the yellow. And if we come slightly proximally, in between the flexor digitorum superficialis and the flexor digitorum profundus, in between plane will be see a popcorn-like hyperechoic nerve, and that is the median nerve. The same nerve, when you follow, this is the short axis, and the same nerve in the long axis view. And if you follow the nerve, okay, so this is the nerve, this is the nerve. I will show in the video also. If you follow the nerve, it will go down the flexor retinaculum towards the hand, and then it will go down, go deep. The difference in median nerve cross-sectional area between at the level of the proximal pisiform bone and the proximal part of the pronator quadratus muscle, that level I have shown. Okay, pronator quadratus is a deep muscle, not always visible at this area, but it is between the flexor digitorum. It is approximately 7 to 8 centimeters proximal to the proximal crease, and then at that area you take the cross-sectional area, and at the level of the carpal tunnel you take the cross-sectional area. Now, the difference flattening will be called if the transverse section nerve is at least 3 times wider than its thick. The thickness should not be greater than 2 millimeters. So actually, there are a lot of these criteria. This is one, but that is not the only criteria. Okay, if you search, this part is not validated properly yet. So this is one criteria, but there are a lot of the criteria you will be finding, but this needs some more time to find out which one is the best. But even now, there are some criteria like that. Some criteria based on the nerve flattening, some criteria is based on the nerve cross-sectional area. But the problem is, in some patient, even with the criteria, it is found the patient is having no symptoms because of the anatomical variations. Okay, so it is called, these criteria are only valid when the patient is having the symptoms of the CTS. Okay, so then only you can diagnose with the ultrasound. Okay, so optimal diagnostic cutoff value for the CS ratio, distal versus proximal. That means at the level there will be flattening at the distal part because of the pressure over the nerve, and if the ratio is more than 1:3, then it should be considered CTS. This is one of the most common criteria that we usually follow, and it is found in this study that is having a specificity of 93% and sensitivity of 91% when compared with the electrophysiological studies. Okay, so what is carpal tunnel syndrome? Carpal tunnel syndrome is an entrapment neuropathy caused by the compression of the median nerve as it travels through the wrist carpal tunnel. This is the most common nerve entrapment neuropathy, accounting of the 90% of all neuropathies. So it is that common. Okay. Early symptoms of the carpal tunnel syndrome include pain, numbness, paresthesia. These symptoms typically present with some variability in the thumb, index finger, middle finger, and the radial half of the ring finger. Pain also can radiate deep up the affected arm, with further progression, hand weakness, decreased fine motor coordination. Patient might say, I have having problem in holding some small object in hand and holding glass even. Okay, and the thinner atrophy of this thinner eminence might be possible. Okay, so this is a quick video of the injection of the carpal tunnel. Okay, so first the needle is up, then we are separating it from the flexor carpal ligament, then we are doing it from the below. We can show you a better video as well. We have our videos too. So the dorsum of the wrist here, this what is important for you is the structures you need to know for the dequervance. Okay, that is the compartment one. Okay, so there are two important structures. One is the ulnar styloid and another is the Lister's tubercle. Okay, and here you are able to see two muscles. Okay, that is the extensor pollicis brevis and the abductor pollicis longus. Abductor pollicis longus lies more laterally or slightly towards the anterior side or towards the ventral side, whereas the extensor pollicis brevis lies towards the dorsal side. Okay, and these two comes within a common sheath. Now there is friction and there might be inflammation here, and this condition is known as the dequervance tenosynovitis. Okay, and I think you know the anatomical snap box. When you hold the finger like this, so this portion above is the anatomical snap box. This extensor pollicis brevis forms the lateral portion, as our anatomical position is like this, the lateral portion of the anatomical snap box, and the extensor pollicis longus forms the medial portion of the anatomical snap box. So anatomical snap box is in between these two tendons. Okay, and here they forms the compartments, and these two muscles are within the first compartment. Then in the second compartment lies these two muscles, extensor carpi radialis longus and extensor carpi radialis brevis. They lies in the second compartment. Okay, and then we'll be able to see the Lister's tubercle, really prominence in the distal aspect of the radius. Then we will be able to see the extensor pollicis longus. Please mute. Okay, requesting to mute, please. Okay, Monish Tiwari, please mute. Okay, so here in between them will be between the compartment 2 and compartment 3, we will be able to see the Lister's tubercle, and this crossing might cause friction and inflammation. This is known as the proximal intersection syndrome, and compartment 2-3 crossing might again cause the inflammation here, that is known as the distal intersection syndrome. Okay, so as they are rare syndromes, we are just mentioning the names, but we are not telling any further because they are not common and you won't be encountering these conditions very commonly, but you should know that there are these two problems as well. Okay, now again after the compartment 3, as I have told, it is the extra pollicis longus tendon. Then next is the fourth compartment, and that is the large ventral compartment. Then we have the extensor indicis and the extensor digitorum. Okay, the tangents of the extensor digitorum and extensor indicis are within this portion. Next is the fifth compartment where we get the extensor digiti minimi, and in the sixth compartment we can get the extensor carpi ulnaris. Again, as the idea today, I'll not be showing these portions. Okay, so this is the whole of the all compartments. Okay, now the first compartment. So just above the radial styloid, if we look, then we will be able to see two tendons in a common sheath. Okay, and they are the abductor pollicis longus and the extensor pollicis brevis. They are lies in the common sheath, and they are inflammation due to the condition known as the dequervance. Now, DES, are you asking anything? If you are not asking, please mute. Okay, so dequervance synovitis is named under the Swiss surgeon Fritz de Quervain, who first invented the contention in 1895. Okay, this is a condition which involves a tendon entrapment affecting the first dorsal compartment of the wrist. With this condition, three of the tendon sheath around the abductor pollicis longus and extensor pollicis brevis develops where the tendons pass through the. Mohan Maharaj, please mute. Okay, so they develop when the tendon pass through this fibroosseous tunnel here, located along the radial styloid distal ridge. Then there will be pain. Now you can exacerbate the pain by the test like ask the patient to first do this and then do this. Okay, first put the thumb in the flexion and then ask the patient to ulnar deviation of the palm, and this condition will produce the pain. Okay, and this test is known as
Finkelstein's test.
Finkelstein's.
yes, very good. So this is the Finkelstein's test. Okay, so that is the clinical test we commonly perform. Okay, now coming to the pulley portion, that is another common disease affecting the A1 pulley, the tendon near the A1 pulley. We all know these are our fingers. Okay, so posteriorly there is the bone, anteriorly there are the flexor tendons. Now, if the flexor tendons are not hold to the bones with the pulley, then what will happen? When the tendons contract, the tendons will come forward like this. But to prevent this, God has given us pulleys. So there are annular pulleys as well as there are cruciate pulleys. Okay, usually for the long fingers, we have 5 annular pulleys, A1 to A5, and 3 cross pulleys, okay, C1 to C3, among which the A1 pulley, near the A1 pulley, what happens? Commonly, the inflammation of the distal tendon occurs when it passes through the pulley. Then when the inflammation occurs, the smooth gliding movement, what happens to our fingers, is hampered. And what happens in those conditions? In those conditions, when we will ask the patient to flex, there will be cut. That means there will be some what do I say, feeling of trigger. Okay, some locking feeling. Okay, first it are not able to flex, then cut, then it is flexing. Okay, if you just hold here, okay, just put it is near the joint. Okay, this is not at the crease. Okay, because our proximal phalanx is from here to here is our proximal phalanx. Okay, this is the whole of his our proximal phalanx, and our crease, try to locate the crease, the proximal crease is slightly distal to the end of the proximal phalanx. If you feel your in your own hands, okay, the proximal crease is slightly distal to the proximal phalanx. So here is my, where my middle finger of the other hand is the proximal junction of the metacarpal and the proximal phalanx. Okay, and here is the proximal crease. So if we see here, exactly at this area, over this area, we have the A1 pulley. And here we will be able to see the, here, so you can see this picture. So here is inflammation and thickening. Now when it is passing over the A1 pulley, okay, this is not the A1 pulley, this is a wrong picture actually. So it is promote proximal. If you see it is a trigger thumb, then it is all right because thumb has less number of pulleys. So here there is inflammation, and what happens? It is the clicking sensation that occurs. Okay. So in the thumb, you can see there is less number of pulleys. Okay. Only A1 and A2 pulleys and oblique pulleys here. Okay, so here in the trigger thumb there is inflammation here. Okay, there is inflammation here. So that was all about the pulley systems, and here you will be able to see the, remember here what happens, the pulleys are not usually visible because it looks like black when we see in the cross-sectional view. You will be able to see the tendon here, and you will be see the black anisotropous part of the pulley. Okay, so this will the hood portion, this black portion is the anisotrophy, and here the upper part is the pulley portion, and this is the flexor tendon. That is the A1 pulley at the cross-sectional view. Okay, so that will be seen in the examination. But before going for the ultrasound, if you have any questions. No, I have time. Not much to see. Any questions?
Sir, what are the interventions we do in the wrist?
That way I will come now, I will show. Already I have told some already. Okay, I have told about the decurvent stenosynovitis. We go for the decurvent stenosynovitis injection. We commonly do the carpal tunnel syndrome injection, the fenestration, Dr. Shubhalakshmi, Dick Whitmer's test, okay? That is the Frankel-Find's test. Ask the patient to do this first, then this ulnar deviation, the pain here, okay? That is the Frankel-Find's test, okay? For trigger finger, as you should examine like this, okay? And you will be able to see the clicking feeling. So these common injections we perform, this 3 is for you. For basic, I think this 3 is enough. In the wrist, the CTS injection. Here, this is the dequervance injection, and here at the finger, the trigger finger injection, because these patients are very common. So let's go for the ultrasound evaluation. Okay. So again, we are not asking the patient to sit because we are now patient ready for the elbow examination, and we are not asking the volunteer to do everything again. So we are doing in the supine position. So first we are taking a towel, folding it and giving below the wrist. This is enough. So iron bottle is not required. So this is the position. It is focused in the elbow. So this is the position. Now we need to palpate the bony structures here. Okay. So here, if we palpate, okay, here we can get the, can they see? Here we can see the scaphoid bone. Okay. And here we'll be able to feel the pisiform and the hook of hamate here. Okay. And first we need to evaluate from the proximal to distal. So let's try with the ultrasound. So we are keeping the aspect marker towards the radial side. Okay, then we can focus from some other places from that side. তুমি একটু আদিকে চলে এসো তো, ওই দিক থেকে ফোকাস করতে পারো কিনা দেখো তো, ওর ওই পাশ থেকে তুমি একটু কাছে চলে এসো। Yes, try to focus from the other side, otherwise they won't be able to see. Pranar mobile. So just so now we are at the proximal portion. Can you see the popcorn-like nerve here? This is the popcorn-like nerve. So what is this nerve?
So median now.
Yes, I have told you, it lies in between the flexor digitorum superficialis tendons, or here it is the muscular portion, and flexor digitorum profundus, okay, deep and superficial flexors. In between this plane, we are able to see the popcorn-like median nerve. Now, as we are coming down, okay, now we started coming down. Can you see the probe? We are slightly gradually coming down, down. Now the nerve is much more clear. Now we are coming farther down. We are close to the wrist. Okay. So when we are close to the wrist, see now what depth, okay, when we are close to the wrist, as I've told, one bone should be very prominent. Okay, so what is that bone?
Unit.
Yes, fine. This is our landmark that we have reached the area of the proximal carpal tunnel by seeing the lunate. Now from lunate, if we go towards the lateral side. So what bone we are able to see?
Scaphoid.
Yes, this bone is the scaphoid. Okay. And from scaphoid here, okay, in the lower part, it is like that. In the upper part, it is like this. From scaphoid, now lunate is gone. Okay. See, in proximal part, slightly proximal, you will see more of lunate, less of scaphoid. And here, as we go distal, you will be able to see more of scaphoid. And from scaphoid, we are able to see one ligament. Okay, that is the origin of the transverse carpal ligament from the scaphoid bone. Okay, so you can see again, I am showing the lunate here. As we go distally, we are able to see the scaphoid here. And we can see the portion of the transverse carpal ligament as well. Just follow the transverse carpal ligament, then you are able to see a structure. Now, to make it clear, let us do some maneuvers. USG, what we commonly do is again increasing the frequency, and 17 is not required. I think 13 is good enough, and need to change the focus. So can you see the median nerve clearly? Yes, that's the median nerve. Are you clear? Yes. Now you can see same nerve which was showing hyperechoic at this area, it becomes hypoechoic because of this tendons. It is along with the what you are seeing, what is the around the tendons, depending on that the thing changes. And here I have said that it is not always visible, but fortunately here it is the visible. This is the portion of the palmaris longus tendon. Okay. So I think few days back someone asked me, do you need a good USG machine? It is true. If you have a good USG machine, you will be able to see the structure so clearly. See, all the structures are clear. Now, as I have told, asking the patient to move the fingers, just move the fingers. Now see, all the structures are moving, but not the median nerve. Clear? Can you see the flexor digitorum longus and superficialis tendons are moving, but not the median nerve?
Yes, sir.
Fine. So you can see each and every tendon clearly and distinctly. Now, if we go laterally and slightly distally also, then we will be able to see the another bone also and artery nerve. So let's move. So here you can see the pisiform bone. It is connecting to the, see the carpal ligament. It is getting connected with the pisiform. Here is the ligament. Okay, here is the ligament. It is coming and connecting to the pisiform bone. This is the pisiform bone. And here again, let me try to clear and make it at the center. So 1 centimeter, I think, all right for this. Yes, 1 centimeter is good enough. It will clear. This one is clear, I think. This is clear. Okay, but in this portion, artery is less thin. Okay. Fine. Okay, now it is very good. Can you see the artery and nerve? No answer. Can you see the artery and nerve?
Yes, sir.
Yes, sir.
This is the nerve. Yes. So this is the ulnar artery and ulnar nerve. And here we can see the median nerve and we can see the tendons below. Okay, now it's time to again see the median nerve, but in the long axis view. So we are applying the same formula here. So what we are doing, we are putting it at the center, holding it, the probe stably on the other hand, and now we are rotating it. So the structure coming and sweeping down. This is the nerve. Okay. Again, look, we are doing it again so that we need to make it more clear. Okay, again we put it at the center and then we are rotating it. So here now we can see more portions of the clear nerve. Now I am asking again the patient to finger. See, median nerve is at the place, but the tendons which are deeper to it are moving. All right, you can see the part of the lunate as well. Can you appreciate, everyone?
Yes, sir.
Yes, sir.
Yes, sir.
Okay, fine. So that is all about the CTS portion. Only the injection I have already once shown. I will show you another video as well. Now, okay. Do you want? Are you satisfied, or do you want to see it more clearly with a hockey stick probe? Are you convinced, or want to see it more clearly?
We want more clearly.
Okay, so now we are going for the hockey stick probe. Okay, that is a very small probe. This is for the smaller structure. This is the probe. Okay. So here, this portion is the medial part of the screen. So we are putting that here at the center in the same way. So here the frequency is higher, so we need to readjust a lot of things. Okay, we need to reduce the depth. So it will be a book-like picture. Okay, but again the problem is you won't be able to cover a lot of structures here. Okay, so you will be able to see clear, but as the footprint of the probe is smaller, so you won't be able to see lot of structure in the same place. Okay, so this is the your median nerve at the center. Okay, this is at the 13 megahertz. Now we can go up to 17 to see even under the small honeycombing appearance here. Okay, that is possible, only possible with this probe. With the other probe, it will show black only. Okay, depth is reduced. I think it is 0.5 centimeter. No, it cannot be reduced further. Okay, you want to, yes. Okay, that is the minimum depth. Okay, so this is the clear median nerve. Okay, now if we go towards the ulnar side, again this is the ligament. Now we are going towards the okay, so now we can see the okay, then we will be able to see the, just a minute, let me bring the pisiform in the same view, then I'll check. Okay, so three structures. Nerve is not that clear now. Slight movement, yes. Now you can see the slightly depth. Focus, increase. Yes. Okay, so you can see the pisiform, you can see the nerve, and you can see the ulnar artery as well. Okay, now you can see it is very much clear. Okay, artery, and by the side of the artery, a honeycomb pattern structure. Okay, that is the nerve. And here is the pisiform bone. So these structures are clear. Then we are going for the compartment 1. So here the trick is first ask the patient to make clear the anatomical snap box. So this is the anatomical snap box, anatomical snap box. Fine. Okay. So here, can you see in the view? Okay. This is the, here there are two tendons. These are actually palpable also. Okay. This tendon you can see in this side. This is the abductor pollicis longus and this is the extensor pollicis brevis. So in this snap box, this tendon is the extensor pollicis longus, this one is the extensor pollicis brevis, and this one is the abductor pollicis longus. So we are putting it over that. Again, the left portion of the screen is towards the dorsal surface. Okay. Now, here near the styloid, you are able to see two tendons. Okay, two tendons together. Okay, this is the tendon of the, which tendon is this? Towards the dorsal surface. Which tendon is this?
Extensor pollicis longus.
This is not the longus, this is the brevis. This is the longus, abductor pollicis longus. They are together. Okay. Now, if we go, so if we want to inject, how will we inject? We'll focus these two tendons. Then from the, usually you can go from the dorsal surface, you can go from the ventral surface. So from this, I am not putting the needle, but I am pressing just to show you the how to put the needle. Usually from this surface, we go to this common sheath area. Okay, we go to this common sheath area and then we inject in this common sheath. Okay, for the dequadrant stenosynovitis. Now we are going to show you. Other compartments are not for basics, so I am not showing as the time is also not now. So we are not going to these compartments, but we are going to most important part, that is the trigger finger, because you must learn the practical parts, what is more important. Okay. So for the trigger finger, so if the patient, we can consider this part that the patient is having pain here or the triggering is in this finger. So how will we will evaluate? So again, we are putting jelly and now we are putting it over the, so this is the so this is the joint. We are putting it over just at this area. So in this area, can you see the classic hood? Okay, let me reduce the depth also. Okay, that is the minimum. We cannot reduce further. Some fine tuning to make it clear. Yes. So here exactly at this area, okay, we are able to clearly see the bone. We are able to clearly see the tendons, the flexor tendons, and by the side, these are the anisotropic part of the A1 pulley. Okay, and if we check in the proximal is the left side of the screen. Now we are just over the joint, and here we are able to see the joint and the flexor tendons. So how we can differentiate those? First, what I am doing, I am fixing the middle phalanx, and we are only moving the distal part. Okay, the distal phalanx, only the longest tendon will move. Now, if we flex the whole of it, then the whole tendon is moving. Okay, so the longest and brevis, now a whole tendon is moving. You can see the superficial and deep part, and when you are fixing, only the deep part is moving, not the superficial part. Okay, so now this gliding over through the pulley is very smooth. There is no obstruction, it is moving smoothly. Okay, and if we move the whole of it, again it is moving very smoothly. But if there is trigger finger, then you will be able to see it is actually obstructing in this area. It is getting obstructed in this area, and here you will be injecting this view, and from the, usually we hold like this, and from the ulnar side, or you can do it from the other side also, but if you are using this hockey stick type of probe, then it is going from the other side is easier from where you are holding. So we need to come here near the pulley at this area, and then around the pulley, if you injecting the steroid, you should inject it around the pulley. Okay, and it is a very effective procedure, and if you do it properly, you will be able to treat the patients with the trigger finger. So how much time is left? Only 10 minutes. So here, next I will show you some video and take questions. CTS video. এগুলো করা যাবে না, এটা পুরো ভিডিও টাইম মেন মোবাইল ডাটাতেই ঢুকে গেছে, এখানেই CTS ইনজেকশন দাঁড়াও, রাখলাম, দেখানোর জন্যই রাখলাম। দাঁড়া, আমি কি রেজিস্টার ঢুকিয়ে দিয়েছি? এক সেকেন্ড দাঁড়া, প্রেজেন্টেশন। Okay, so okay, first I got the trigger finger injection. Now we are going for, so let us show you first the trigger finger, the injection of the A1 pulley. A1 pulley is situated proximal to the, slightly proximal to the first proximal crease of the fingers. So if this is the crease, here is the carpometacarpal joint, sorry, metacarpophalangeal joint, and here we can find the A1 pulley. So we have to first see the joint. Okay, so we are putting the probe in the long axis view. So here we can see the joint, that is the metacarpophalangeal joint. Okay, so in the left side of the screen we can see the metacarpal zone, and in the right side we can see the phalanx, and slightly proximal in this area we can found the metacarpophalangeal joint. But before that I want to show the deep tendons. So these are the fibrillar tendons, that is the, if we move the finger along the both the phalanges, that is the middle and distal phalanx, we can see the whole tendon moving. Now if we fix the middle phalanx, fibers of the so in the short axis view, this structure A1 pulley structures. So inject or drug here for the trigger finger or the stenosing tenosynovitis of the finger.
No voice.
Hello?
Yes, sir. Now you are audible.
Yes, yes, fine. Sit, yes. Okay. I love videos. Okay. Sit, yes, I got it. So, this one is the injection for the CTS. Please mute. So here we put the median nerve in one side, and now we are just moving in between putting the needle in between the flexor retinaculum and the median nerve. Okay, so just above the median nerve, we are first putting the needle. Okay, please mute. There is too much noise. Hello.
Keep it open and
Okay, now we are separating it with the fluid from the flexor retinaculum. Okay, and here sometimes we need to apply a little twist pressure because in those conditions we need to go for the fenestration procedure. So we are doing the fenestration now. Okay, so sometimes we can do it in a better way as well. So it was a very sticky. So now upper part is done. Now we are going to the lower part and then again injecting below the median nerve.
How much volume we inject?
Okay, usually 3 to 4 ml is usually enough, but sometimes we can give a little more as well.
Okay.
Usually 5 ml syringe is taken and then we have completed the procedure. That was a different video. So more or less that was the CTS, and this is, see, when there is a disease, I have shown you, not should not, I have not shown you the, see this condition. So this is the long axis. Okay, and in some patients you might get it is more compressed. Okay, see here there is the before, there is the dilatation. Okay, this is the stenosis part and this is the prestenotic dilatation of the nerve. Okay, so that is the median nerve and the CTS injection. Unfortunately, we don't have the DQ injection. Okay, if we have get one, then I will share. Okay, but whatever. Okay.
Also, can we see a trigger finger also injection? Trigger finger.
Okay, depend. See, previously we have done a lot of procedures, but unfortunately we don't save them. Basically, online course started after the lockdown. So what happens? Previously, the students used to come here and with the patient they used to see. We never record. So now the patients are less in last 1.5 years. Whatever we got the patients, we have made the videos. But previously, we have not made videos when the patient number of patients were much more.
How
Okay.
much volume we injected for carpal tunnel?
Okay, carpal tunnel, I have already told just now. Usually 3 to 4 ml is good
No,
enough.
sorry, trigger finger.
For the trigger finger, usually 1 to 2 ml is good enough. That is more.
We use better the dextrose 5%.
See, prolotherapy has evidence. Some physicians use dextrose 5%, but till date, for if you ask for me, I have not used dextrose 5%. Rather, I have used PRP more rather than the dextrose.
Okay, thank you.
Sir,
So 10 mg or 40 mg of
Triamcinolone should be used. What should be used?
Actually, 40 milligram is not required here. 20 milligram is good enough for the small joint injection, small joint or the small nerve injections. 40 milligram is much higher, so that much is not required here. Okay, you can give something 20 milligram or 20 between 20 to 40 is good enough.
Sir, for CTS, from which side we have to enter? Radial or ulnar side?
Okay, I enter from the ulnar side. I found it better between this ulnar artery and nerve and the this thing median nerve. In with that interface, I usually prefer to enter, but there is no fixed rule. If you want to enter from the other side, you can do that also.
And sir, during penetration of carpal tunnel syndrome,
Dilatation, stenotic dilatation, okay, of the nerve. Yes.
sir, during penetration of carpal tunnel syndrome,
Yes.
which fibers we have to fenestrate? Transverse carpal ligament have
Yes.
two
Yes.
fibers.
The fibers of the transverse carpal ligament. Fiber is the this thing. Okay. Actually, I have a better video of the fenestration also. So let me show you. So for that patient, CTS. তুমি দিলে না মাত্র?
Folder.
যা। আমি দিলে তো বটে। একবার দাও তো। কোথায় একটা কপি করে রেখেছেন, কোথায় যে কপি করলাম আমি নিজে ভুলে গেলাম। ওকে, নো প্রবলেম। আর আবার দাও না। Just a minute.
Sir, I have one more question. During
Yes.
during hydrodissection of carpal tunnel syndrome, distally how much we can go? What is the distal limit?
See, the problem is distally when the nerve goes down and that part you cannot go. So usually we do at the level of the distal palmar crease or in between proximal to distal palmar crease. Okay. Much distally you won't be able to see the nerve.
But sir, transverse carpal ligament has itself a breadth, no? I mean,
yes, transverse carpal ligament is having a breadth. It is true, but the thing is, you won't be able to do in the whole part of it. Okay, but if you do in one area, okay, as it is coming from below upwards, okay, it is coming from this side to this side. So in the stenotic area, where we got the in the picture, you have got this picture of the stenosis, na? In that area we do the fenestration, but it is not only the fenestration, there is the fenestration along with the hydrodissection, both works. Okay, it is not only the fenestration that is working. See this video. I have started or not? I'm not started. Okay, no, I have started. Can you see? Can you see the video?
Yes, sir.
Yeah, we can see.
Okay. First we are injecting. So this drug is moving up and down as well. And remember, don't push here. You are not the patient is having very stiff in this area. Okay, they was not able to enter there in between the interface properly. So there is some pain. So I'm injecting slowly, doing the hydrodissection and then injecting. Okay, now we are going to the proper interface. Okay, this part is the fenestration portion. And you should be careful not to injure the nerve. Okay, now below the nerve. Okay, can you observe the halo sign? So that more or less completes the procedure. Okay.
So how
Now-
many time we have to fenestrate and how long its effect last?
Okay, so there is no strict guideline that, see here also, okay, in the last part of the video, again you will be able to see that dilatation. Okay, here you see this portion is the constricted. So I have done the procedure in this portion. Now we are checking with the other view as well. Okay, that where we are the right constricting area or not, the needle tip is at the same area or not. Okay, and here see the compression is much more. Okay, and regarding how many times we need to do, there are no specific rules yet. Okay, so number of studies are limited, so we do not really know that exactly how many times or how many time and which is the best time, how many times is the best parameter, or the how much time is the best parameter. These things are not yet established.
Sir, how long the effect lasts?
Okay, it depends on the patient, and usually the effect is long lasting. In some patients, you might need to do 2-3 times, and usually in a gap of 3 weeks or 4 weeks. But the result is most of the patients is good. So I think this is the time to conclude today's session.
So how many times these injections can be repeated?
Usually maximum it is repeated for 3 times. Then if then also it is not responding, then we send for the surgery. But the number of patients that are not responding is very less. So I think it is time to conclude. Bye bye for today.
Bye, sir.
Thank you, sir.
Welcome.